As a diagnostic tool used to categorize psychiatric illness, the DSM has been subject to multiple criticisms over its history. Though the DSM brings multiple advantages to clinical practice, such as the standardization of disorder for accurate treatment, guiding research in the mental health field, and providing a valuable framing reference during therapy sessions, its drawbacks are worthy of discussions. Misdiagnosing a person is always a possibility because using the criteria to determine if someone is disordered based on symptoms alone is not a completely reliable strategy. Also, the risks of stigmatization once one is labeled disordered are an issue for the patients, as the patients could be seen by society as having an inherent problem, which would cause them to be treated differently based solely on their label. However, I think the biggest change and the potential problem for the DSM over its 5-edition history is the proliferation of disease categories. In the DSM-1, there were 102 categories of diagnoses, increasing to 182 in the second DSM, 265 in the third DSM, and 297 in the fourth DSM. The DSM-5 also added a few new diagnostic categories such as binge eating disorder, hoarding disorder, and premenstrual dysphoric disorder.
In this video essay, I argue that the increase in disease categories within the DSM can be attributed to a need for reliable and valid classification methods to meet the needs of an ever-changing medical insurance landscape.
There are a variety of explanations for the increase in categories. One explanation includes the need to create a more broad system of categorization that is justified by scientific investigation. Because the DSM has had its validity questioned, validity meaning whether a category can be based in scientific or empirical reality, the National Institute of Mental Health launched the Research Domain Criteria Project in 2010 to transform diagnosis by incorporating genetics, imaging, cognitive science to lay the foundation for a new classification system they feel will be more biologically based. This criteria project was intended to complement the DSM-5, and with it being released a few years before the DSM-5, it represents an increased need to ensure the scientific validity of all the new categories appearing within the latest versions of the DSM. An additional explanation for this increase is the focus on reliability within classification systems. Horwitz explains the importance of this in a large categorical system. In the absence of a valid definition of mental disorder, there is no limit to the number of discrete conditions researchers and clinicians can develop. Basically, a medical professional can create a brand new category to explain the behavior of an individual to align with the DSM model of ensuring a condition is properly diagnosed. Reliability in this case refers to the ability of a classification model to accurately describe the type of condition a patient is dealing with so that practitioners can prescribe treatment and provide a clear way for third-party payers to financially support the treatment. The reason that new categories keep appearing in the DSM is to confirm that insurance would pay for treating a specific problem and create effective data collection strategies. There has to be a system of instituting discrete illnesses to aid the logistical and economic processes of medical companies. Horwitz notes, payment through the insurance brought not only a lucrative source of funding, but also a demand for greater accountability to external economic forces. The rise of third-party payers contributed to pressures to impose a categorical rather than continuous model of illness. Dynamic psychiatry, which reflected a model of illness that was continuous and non-discrete, would not be able to account for the rise of third-party payers who require symptoms be explicitly associated with the disorder. In addition to the reliability of this model, insurance companies and government programs required accountability as they funded psychotherapy. Those who provided medical treatment to patients needed to give the payers concrete information on the clients they treated. Establishing discrete diagnoses reflected the economic reality of medical insurance.
There is reason to believe that the increase in disease categories aligns with the increased need for validity in describing a disorder's foundation.
For example, this increase could be explained by a desire to validate psychiatric categories through biology, as noted earlier. In the Bortolotti and Broome paper, Mental Illness as Mental, they describe how the development of the DSM classification process relied on validation from science and biology. Basically, in this development, the notion that mental illness could be explained by psychological factors was not accounted for in the taxonomic process. The classification in DSM-4 was based on the assumption that science itself will tell us how to classify psychiatric disorder. Biological validators were consulted to aid the DSM taxonomic process based on the conviction that patients with the same diagnosis share an underlying pathophysiological process. There is an assumption that patients diagnosed with a particular mental disorder have universal psychological characteristics that lead them to developing the condition. The influence of biological realism, which states that psychiatric disorders can meet the criteria for being natural kinds, meaning that they can be reducible to explanations by neuroscience and cognitive psychology, in this classification system is clear.
Any new category instituted over the course of the DSM's history seems to reflect the idea that one can justify the existence of a medical condition based on scientific research. There are a couple of DSM categories that are worth exploring that highlight the need for increased validity and reliability as new psychiatric illnesses are developed.
According to the diagnostic features of antisocial personality disorder, those who are diagnosed with this condition display a consistent pattern of disregard for the rights of other people. This behavior often begins in early adolescence and continues into adulthood. Determining whether one has this disorder relies on systematic clinical assessment and collecting information from collateral sources. These examination procedures and extensive data collection seem to imply a scientific rigor designed to validate the medical standing of this condition. Reliability is also evident in the structuring of the diagnostic criteria, as those who diagnose the person with the disorder require that the symptoms be indicative of the condition in question. For the clinician to be accurate in their diagnosis of antisocial personality disorder, the symptoms need to reflect universally agreed upon standards that would indicate distress, dysfunction, or an inability to behave responsibly. As stated previously, in order to provide treatment to this patient, medical insurance providers require the systematic and reliable classification of APD. Without a thoroughly defined illness, third-party payers would not be able to efficiently determine how an individual is suffering and provide treatment that is geared specifically towards the person.
Furthermore, this focus on reliability and validity within the criteria highlight an etiological conception of disorder, but I will get into this later.
An analysis of gambling disorder within the DSM-5 additionally reveals a heightened importance of scientific validity. This is especially clear as the criteria note a variety of risk factors that indicate the genetic history, which may play a role in the disorder's development. On page 588 of the DSM, gambling disorder lists temperamental, genetic, and physiological, and course modifiers. Temperamental factors describe how the disorder could align with other disorders. Course modifiers describe how the disorder can be resolved by the individual over time, but genetic and physiological factors seem to best convey how the classification relies on validity. Given that gambling problems reside more in monozygotic than dizygotic twins, and first-degree relatives with alcohol use disorders, this is clearly an attempt by the DSM to provide a basis for the disorder based on genetic explanations. The introduction of pathological gambling in the DSM-3 and its modification of classification over time can be attributed to this kind of scientific plausibility. This disorder also promotes reliability for clinical diagnosis and structured payment plans from insurance through its specifiers, clarifying whether the disorder is episodic or persistent, in early remission or sustained remission, and the severity is critical for the providing of right treatment. The role of differential diagnosis is also necessary in ensuring that the disorder is problematic in the context of normal human functioning. Professional gambling, manic episodes, and other medical conditions can be differentiated from the gambling disorder, which is necessary for reliable data collection of affected individuals. An increased emphasis on scientific validity and economic reliability dominate the proliferation of categories in the DSM, and there is reason to suppose that the basis of this constant generation of categories exists to complement an etiological theory of mental illness.
As new disease entities manifest in the DSM, it's clear that many of the criteria stipulated for diagnosis reflect the conditions harmed as judged by society, and also reflect the inability of mental mechanisms to perform their natural function.
A normative theory of disorder, such as the one put forth by Edwards, does not properly serve as the foundation for these categories because these features often highlight the person's irresponsible nature, whereas in Edwards' theory, the mentally ill person is not held morally responsible for having the condition. Looking at antisocial personality disorder, we see descriptions such as how individuals with the disorder tend to be irresponsible in financial obligations and work, just to name a couple. With how the descriptions are phrased within the DSM, one can be morally responsible for having the condition, and this is further supported by the claim that the sufferer has a lack of empathy, inflated self-appraisal, and superficial charm. So a level of control over their behavior is implied here. Not only is the disorder viewed as harmful in the social sense, the type of aggressive behavior, such as aggression to people and animals, destruction of property, deceitfulness, theft, serious rule violations, seem to reflect a dysfunction in the mechanisms responsible for maintaining proper behavior.
Regarding gambling disorder, the social harm that entails is that it jeopardizes a lot of valuable social undertakings, such as relationships or career opportunities.
The functional consequences of gambling disorder also demonstrate a dysfunction in psychosocial mental health and health systems. Distortions in thinking indicate a level of dysfunction that is not naturally selected for.
The etiological theory of mental disorder best explains the continued increase of categories in the DSM. By representing a disorder's social harm and dysfunctional mechanisms, the DSM can create a sense of reliability in the economic and medical insurance landscape, and validity in the empirical sphere with respect to disease classification.
If someone is diagnosed with either disorder, it would be wise for them to take a positive psychological approach. Popularized by Maddux, positive psychology serves to reject the issues of clinical psychology, which often only serves the interests of medical companies and those who seek to profit from prescribing treatment to sufferers. The illness ideology and the DSM are sustained not only by the individuals and institutions whose goals they serve, but also an implicit set of logically flawed and empirically unsupported assumptions about how to best understand human behavior. The sentiments described in this example wholly reject the validity and reliability approach that DSM pursues, but they come with recommendations on how to improve the approach towards mental illness. Maddux suggests the dimensional, interpersonal, and case formulation approaches, which are options that medical providers and patients can take to make improvements in their mental health.
Though the DSM provides a valuable framework for understanding how symptoms can align with a specific illness, changes need to be made to reconstruct an ideology that has for so long located problems within the person, when changes could definitely be made socially to encourage people pursuing better mental health options.